This is Paul Kent, the medical director for FibroFighters. We have a chance to do a quick interview with Dr. Jordan Tasse, interventional radiology at Rush, who's seen more fibrolamellar patients as an interventional radiologist than anyone in the country, and has been a leader in this field with new ideas and new approaches. Welcome, Dr. Tasse. Do you want to introduce yourself a little bit?
Yeah, thanks, Dr. Kent. I'm Jordan Tasse. I'm an interventional radiologist, director of interventional oncology at Rush University Medical Center in Chicago. So proud and happy to be here.
Yeah, how many patients do you think you've seen?
At Fibrolamellar, we've had a Fibrolamellar program at Rush since, 2017 or so. I think we've seen well over 100 patients, probably closer to 125, 130.
That's great. Thank you so much. Now, what would you want doctors who aren't familiar with this to know from an interventional radiology point of view? What's some important information to have out there?
Yeah, that's a great question. I mean, there's a lot of people that don't understand really even interventional radiology is a brand new field in the field of medicine. It's only been around, 20, 30 years, and it's always advancing. It's very technology driven. It's minimally invasive. And so we do a lot of different types of treatments for patients that have cancer, from, the simple vascular access, portacath placement, line placement, to biopsy for diagnosis, to kind of more complex type procedures where we do lots of cancer treatments, but we do them through pinhole incisions. So, there's a lot of different options that we can offer for patients that have fibrolamellar carcinoma, either trying to get them to surgery or for treatment of their primary metastatic tumors.
Great. So how do you think about fibrolamellar differently than you think about other liver tumors such as hepatocellular carcinoma?
Yeah, and there's a huge difference. And I think our experience has kind of shown that over time that it's just a completely different disease process. I have a lot of experience treating adult type HCC. Majority of those patients have underlying liver disease, whereas vast majority of fibrolamellar patients are young and healthy prior to diagnosis. And so they don't have those underlying kind of issues. And that allows us to kind of be a little bit more aggressive with a lot of our treatments, and it just opens kind of the potential opportunities or options up for a lot of fibrolamellar patients. So I think they're definitely very different disease processes, and I think we've shown that over the years.
Thank you. Dr. Tasse, what is Y90? I hear a lot about that.
Yeah, Y90 is it can be, a lot of times there's different acronyms for that mean the same thing. So if you ever hear of Y90, it's the same as TER. It's the same thing as radioembolization. What it is yttrium 90 is what Y90 stands for. It's a radioactive isotope that we can put a tiny catheter through a pinhole incision in the groin, and then everything is inside the body, and thread the catheter up into the artery that goes to the tumor in the liver, and inject very high dose radiation directly to the tumor from within the artery. And that has a lot of inherent benefits to it comparatively to other types of kind of radiation therapies, and that you're giving it directly to the tumor. So a lot of the potential risks and side effects of having to go through the skin or somewhere else to get the radiation there are not present with this treatment. And that also allows us to give higher doses of radiation to the tumor.
Great. And does this, if you do Y90 to a tumor, does that mean you don't have to do surgery on it?
Depends on the size and the clinical scenario, but certainly Y90 does not preclude surgery. If you have Y90, you can certainly have surgery in the future. For very small tumors, there's emerging data that Y90 is comparable to ablation. In some cases, comparable to surgical resection. Certainly surgical resection, when it's an option, is the gold standard for treatment of cancers. However, as we get more experience in technology with the Y90, it certainly is a very, very effective treatment for the cancer. And then we also do it in other settings where surgery is not an option, and we can treat the tumor. And oftentimes, we've had patients over the years that have been able to be converted into a surgical candidate, which is often our goal with, the tumor's too large for resection up front, but then we do the Y90 in conjunction with systemic therapy. And then the tumor shrinks and the patient is then a candidate for resection, which is oftentimes our goal.
And of course, the recovery's really quick, and you don't have to stop systemic therapy is another important advantage.
Exactly. Yeah. Most of the patients, almost all the treatments that I do are outpatient. The patient goes home same day or the next day, depending on the scenario.
You mentioned earlier ablation. What's an ablation?
Ablation is just a broad term for basically different ways that we kind of kill the tumor locally. Either most commonly, you put a probe, very small needle directly through the skin into the tumor, again, no incision. And then you either use thermal ablation, which is microwave would be heating the tumor, or cryoablation would be freezing the tumor. And you freeze or heat the tumor locally to such a degree that the tissue cannot survive. And so it kills the tumor in that regard. There's also other kind of newer ablative technologies like irreversible electroporation, pulsed electrical field ablation, which are non-thermal. And so they allow us to kind of do treatments of the tumor without having to worry about thermal energy causing damage to surrounding structures, depending on the location. And then, that those are different types of ablation. We also just started doing, I think we're one of 5 centers in the country that has an ablation in the liver called histotripsy, where there actually is no incision. So it's basically uses ultrasound energy to kill the tumor from the outside. And so the patient basically wakes up and there's no Band-Aid or nothing or anything because there's no incision. So that can be a really great option for patients with a tumor in the liver.
Oh, that's great. And again, no pain or very little pain and quick recoveries. Don't have to stop other treatments.
Yeah, generally we really love when we can continue the systemic treatments. Obviously, those are very important, and so we don't want to stop those. And for vast majority of ablations that we do, we don't have to stop any of those.
Wonderful. So now, what about how's the immune system work together with with what you're doing? I've heard a lot about that as well.
Yeah, the immune system is kind of one of the main research kind of aspects that I'm very interested in. And there's in the world of oncology, there's massive amounts of research going. But typically with tumors, they can evade the immune system. A lot of people have some microscopic tumors circulating throughout their body that the immune system just kills before it becomes primary cancer. However, when tumors become larger, they become resistant to the immune system, and so that's a problem that we deal with. And there is emerging data to support different ablative and even radiation, Y90 external beam radiation, that it can help the immune system recognize when you kill the tumor, either by doing a radioembolization or by doing an ablation. It releases dead antigens from the patient's bloodstream that the immune system can now recognize. And potentially, if patients are on immunotherapy, checkpoint inhibitor therapy, potentially their immune system can recognize those dead antigens from the tumor that was killed and use that as a guide to go search for tumors elsewhere in the body. Certainly early on experience with this, and it's something that I think is really, really exciting about the future of cancer care. We're still not quite at the point where we can definitively predict when this is going to occur, but we do everything we can to kind of maximize the potential.
Amazing. And what's the youngest child you've done with fibrolamellar, do you think?
I believe 6 years old was the youngest. And fibrolamellar, obviously is typically in young children, adolescents, but we occasionally see patients that are older with the disease. Some have lived with it for quite some time. Others were just diagnosed at a later age. So I think the age range is from 6 to mid 50s.
What would you tell a new patient? Should every new patient have a consultation with interventional radiologist?
I certainly think, with discussion with their oncology team, and I think, obviously the Dr. Kent and Tom Stockwell at the FibroFighters do an amazing job kind of, seeing these patients and helping them also. And I think with any patient with cancer, I think I always recommend a second opinion, just to get a different set of ideas. It's just different people are doing different types of therapies. So it's a great idea to get, several, sets of eyes on what's going on and get a second opinion. But I think interventional radiology definitely has a role in a lot of these patients. And so I would recommend at least consideration, from the oncologist with an interventional radiologist to see if there's something that could be offered.
Great. Anything else that you would like our audience to know about what you do in your field?
It's just a very, up and coming kind of technology driven field. So we see new therapies almost changing the standard of care within our specialty almost every year to several years. So it's a really exciting field. Everything is moving towards more minimally invasive. If we can get to a point where there's less open kind of large surgeries, less recovery time, less morbidity, and that's very important. So that's sort of why I choose the field, and I love what I do, and I'm very excited and honored to treat a lot of the patients that have fibrolamellar carcinoma.
Great. Thank you very much. Really appreciate all the dedicated service to this community and your expertise that you've developed in this rare disease.
Thank you, Dr. Ken. It's my honor.
Right.